we started with the University of Toronto under Alan Bokins to set up MMed in reproductive health. Then we later on, Barry Rosen, again from University of Toronto, helped to set up the Gynecological Oncology Fellowship. And just about now, we've also set up a fellowship in MFM under Professor Nano Cool. I'd like to say that clinical pastoral education, which is spirituality, is also a subspecialty. And at the current moment, it's located in maternity. So we might be seeing it as a subspecialty in maternity. And it's guided by Professor Eunice Kamara of the School of Arts and Social Sciences. So this is a committee. You might probably recognize some people, but at this time we had a meeting with the Professor Jim Lemons and members of School of Medicine, in Public Health, and School of Nursing. And on the other side, we had people from the School of Theology, Philosophy, the department, so that this is what eventually formed the Eldoret CP committee. Now, coming to the point, I think in Africa, one can say that no misfortune occurs without a reason. In fact, there are no natural causes of misfortunes. It's usually a neighbor, a relative, somebody with a bad eye, or just generally witchcraft. So if I were to say what witchcraft is, I think witchcraft is some kind of misfortune that is created from an external force. And spirituality actually addresses misfortunes. So one would start off at that point to argue like that. So I've picked a few typical quotes that probably inspire spiritually. And I'm starting with the work of Descartes. Descartes says, I think, therefore I am. I think this is French, cogito ergo sum. And this is the basis of the Western culture. In the other words, once you are able to think, then you can create what you wish to do. And then there is the Bantu culture, the Ubuntu philosophy, which says, I am because we are. Here, it is a communalism, kind of African socialism. It operates with this, that you are because we are. And then there's another philosopher, it's a religious philosopher, theologian, John Samuel Mbiti, in 1969, who said, Africans are notoriously religious. Perhaps he would have said that Africans are notoriously spiritual. And then I was at the point of Eliud Kipchoge in 2019, who said, no human is limited. What he was actually talking about is that the only thing that limits a human being is in their own mind. That is beliefs, attitudes, and actions. Those are the things that limit people. So by just overcoming such limitations, then one can perform any event. And then the NICE theory of 2019 is saying that silent beliefs empower persons. So that is a textbook that was written by Mbiti, which is talking about African religions and philosophy. And in that book, there's wide coverage of the African thoughts, where we are seeing that in Africa alone, we have more than 3,000 tribes, and each tribe has its own spirituality that is guiding events in their lives, including marriage, procreation, management of death, what we are calling witchcraft, and all those. So the purpose of spirituality is really to see how to integrate and create holistic health in maternal and newborn health, or just generally reproductive health. But this can extend to the whole of an individual's health. So we see holistic health as a product of the mind, the body, and the surroundings. And indeed, it consists of health, wealth, and happiness. And those three things can be interchanged. You could start with health to create wealth, but still you need happiness. Or you could start with wealth to create health and then happiness. So it's best when the three are achieved at a go. And holistic health is actually psychobiosocial, even by WHO definition of 1948. But then the predicament is that the modern healthcare provider is largely biomedical. I think that's because of the way we are trained and the way we practice. So in a way, one could say that we are unsuitable for achievement of holistic health because we are mainly biomedical. And what has been shown very clearly in the process of this project that we are going to talk about is that spiritual needs of caregivers, families, and seekers of care has been ignored in all health facilities, especially in maternity. So how did we develop this model of holistic health? We can say the current model that we are talking about and the one we use in the School of Medicine is the biomedical model. It's basically medical model, meaning that we are focusing on disease without focusing on health as such. So this is how we developed the current model that we have adopted for spirituality. Now, so we say the current model in the School of Medicine is a biomedical one. And in 1977, George Engel was the first to come up and oppose the biomedical model, which to him was unsuitable. And he called it biopsychosocial model. But then further on, I think we established that everything starts in the mind, and then from there, it can go to other parts of the body and society, and then back to the mind again. So the mind is the leading. So one would argue that it would be better to adopt a psychobiosocial model. And this arises from the application of the general system theory, where we see that inputs plus activities produce outputs, outcomes, and impacts. So that's the basis of how we developed this model. So the biopsychosocial model argues that it is the body that is the starting point, then thereafter the mind, and then the surroundings. But as we are arguing that it would be better to adopt a psychobiosocial model where the mind is the main thing. So the red should be in the mind rather than in the body, according to the diagram that we are projecting. So what is spirituality? Spirituality, put it very simply, is actually the connectedness of things in the universe. It's what connects creations, what connects events, and it's kind of sacred connectedness. They call it sacred because of the feeling that we could not understand what it was. But I think the argument is that although it's not necessarily religion, but it's this connectedness that is necessary for the existence of the universe. And it could easily be electromagnetic and biochemical. And it's from this that then you could see the dimensions of spirituality and the domains so that it can be applied for medical purposes or to achieve holistic health. Now, which are these dimensions? The dimension that we start with is the cognitive one, during which we focus on how to attach meaning, value, and purpose on things. And it actually involves the process of introspection. In other words, examining for what it is that would be important with the particular thing you are doing. And then it's followed by the emotional dimension. And I want to say that this is the most important area because it regulates feelings. And during this time, we make judgment and decide whether something is good or bad. And this is the part that we are saying that may have been ignored by the biomedical approaches. So that at a given time, there's what we call the internal mental dialogue. So when it's negative, then you get fear and development of loss of hope. So that in my view, I feel the biomedical, the emotional dimension is one of the most important. And then from this dimension, one can start focusing. In other words, you can project beyond what you can see. And during that time, then one can make inferences, things like revelations come and prophecies. It's after that that you come down again to the physical dimension. This is the application phase. And actually, in terms of spirituality, one can derive tools that can help run the mind of a human being as M access tools, because M means that from a marginalized position, one can proceed to the time of awareness, followed by courage, which is coming from the emotions, then capacity building, which in real life, it's the part that we mobilize resources for effective action, so that E stands for effective action. And this eventually leads to self-sufficiency. So the human being has this capacity. There's none who does not have. So the tools are derived from dimensions of spirituality. Then I want to focus a little bit on the domains of spirituality, because these are the sources of capacity. In other words, if we are to develop our capacities, the starting point is the personal domain. The personal domain is what regulates our beliefs, our feelings, and our actions. And it's actually, put very simply, it's the character part, the integrity. So self-discipline is what regulates this. And then the interpersonal domain, this is also a very powerful domain because it creates partnerships with other human beings. And that part now helps because we help form common goals, mutual bonding, cooperation, and sharing, so that working together and so on comes from this dimension. That is the domain. So the environmental domain is equally important, and that's where we are saying, how do we connect with other creations? And this is where we get sustenance. And the sustenance we are talking about here involves conservation and preservation of the environment. So eventually, the fourth domain is the supernatural domain. This is the domain of spirits. Things like our ancestors are at this point, the gods and the living dead, they fall into this. And it's really an abstract domain, and it gives us the intelligence, the awareness with which we do things. This particular tool, I think, is a summary of what we've been looking at in terms of spirituality and how we have developed it. And it just shows how well-being relates to the mind, to the body, and the surroundings. And this expands to the supernatural, which is why we talked about the domains and the dimensions. The dimensions are deep inside the brain. Hello?
Yeah, kamoja.
Okay, so the M-access tools we talked about are running the brain. And while the domains provide the sources of capacity that we need for sustenance. and spirituality is at the center. In other words, spirituality is a combination of the biomedical, the psychological, and the social cultural. So the CP project that we started in maternity in 2015 is called the Clinical Pastoral Education, which is really by the School of Arts and Social Sciences together with the College of Health Sciences here. And as we have said before, the aim is really to integrate spirituality into maternity in order to provide holistic care in Western Kenya. But one could go beyond, perhaps if we go beyond and we reach the COMESA countries, I think we will still be providing a service that starts off from the 22 counties where MTRH is functioning. So this model is an academic model. We call it a MIS, academic model for integrating spirituality in the hospital settings, and consists of three aspects. The first is the training aspect, where we use curricula to train the hospital chaplains, so that the hospital chaplains then will come in to provide care, which is actually missing within the hospital setup. And they also eventually move over to the communities. There are times they move together with the COPS group in order to improve the spiritual care in the healthcare settings in Western Kenya. So we did an initial baseline survey in order to see the situation in which we live. And here in phase one, we created a research protocol where we integrated the tools that they use in America together with our own setting so that we can reflect the African setting. And we collected data, which then and in the second phase, we moved on to train the chaplains to give spiritual care within the hospital here, especially in maternity. And they are working beyond prayer. So then phase three is now applying the recommendations that come from this. So from phase one, we concluded that 40% of mothers who deliver in Kenya deliver at home because of they feel it's difficult for them to get timely skilled care. And the spiritual aspects of health have received little attention, so that one would say that the dimensions and the domains of spirituality that we talked about do not really exist within our hospital setting. So there's disrespect and abuse by healthcare providers sometimes, and we feel there's need for professional hospital chaplains to be trained and be situated in the hospital settings, because the ones who are not trained mainly focus on how to pray. And also, it came out very clearly that there's a lack of essential knowledge on what spirituality is at research level. So it's during this time that we are able to create the framework that we have projected earlier on. So in phase two now, at the moment, we have now established the Kenya Chaplaincy Training Center, which is at our car park near Mother Baby Hospital. And we have now the Department of Pastoral Care Services, which is functioning. And we have produced 5 cohorts of spiritual care providers who are now being recognized as health personnel. But I think this needs to be worked on, so that then we can say that holistic healthcare becomes available in Eldoret, not just for patients, but for caregivers, students, staffs, and their families. So that is the model that I was presenting, which is a psychobiosocial model. It is motivated by a theory that we also showed out, which says that silent beliefs empower persons to empower themselves because they engage those access tools and also draw capacity from the surroundings that we talked about. And this way, they can achieve a holistic health. So we went on briefly to look at the situation before and after integration of spiritual care in our setup. And we've seen that decision making, one would say, has significantly improved after we introduced CPE. This is through asking the mothers who are in the mothers' hostels. And even decision making has improved. We can say for individual mothers that received this care, distress and anxiety decreased. And I just want you to note that Africans really believe in miracles, whether it was before or after this project. There's a strong belief in miracles amongst the Africans. The other thing is that we have noticed after introduction of the CP project, there's spiritual support by the medical system. And yes, so at the end of the day, we are trying to propose that maybe we integrate this spiritual care more within the hospital by holding now an awareness meeting between the doctors and nurses through workshops, so that then perhaps for purpose of getting what we call patient-centered care, then we need to alter curricula so that we could probably empower the undergraduate, the postgraduate, and the subspecialty, the students in our setup. So in conclusion, I would say that we need to make sound health policies that include spirituality. Because what spirituality is in this case is what one believes, convert it into speech, and later on into deeds and action that support holistic health. It can also be applied in M-health and e-health, because right now, because of the Zoom technology. So I'd like to acknowledge our supporters, and here Professor Jim Lemons of Indiana University, through the grants that he gave us, then the School of Arts and Social Sciences, our College of Health Sciences, which takes on the School of Public Health, School of Medicine, together with the nursing, and also the Philosophy, Theology, and Religious Studies Department of Moore University, together with Productive Health. This was a visit at the Kasubi tombs, which are in Uganda near us. It's a very spiritual area where they bury the Kabakas. So thank you very much. I want to complete at this point. Thank you.
Thank you very much, Dr. Nyongesa. I'd like to get reactions from those who are listening through the question and answer or through the chat.
Allow me to ask a question. I don't know if I'm clear. I would like Dr. Nyongesa just to explain to me the role of biochemistry in what he has just presented. Thank you.
Thank you, Professor Atakwena. I think the biochemistry has a critical role because of serotonin. Serotonin is a hormone of happiness. Dopamine is also one. Generally, endorphins in the brain mediate happiness. And it's thought that the thoughts or the beliefs that people hold stimulate production of these hormones and therefore create happiness, health, and well-being. Thank you.
I don't know if I can ask a question. Can the same model be applied to the medical patient, seeing that whenever we deal with this patient, whenever we care for this patient, we tend to care them holistically so that we can also do the spiritual aspect, because sometimes we tend to forget. And also being a medical personnel, I don't know the medical legal issues if we tend to bring in the spiritual aspect, because we don't know how it will impact on the medical legal issue. Thank you.
As you can see, if you look at the components of spirituality, they consist of the scientific part, which is the biomedical, then psychological part, and the sociocultural part. So in a way, we are addressing the risk factors that cause disease. We are addressing the effects of disease on the psychology, which is disease, and then the effect on the body, which is now the disease part. So it's within the medical ethics, and medical ethics is a component of spirituality during training. So it's not unethical. It is an enhancement of the psychological counseling that we have at the moment.
Thank you.
Thank you very much, Dr. Nyongesa, for that presentation. This is Balidawa here. My first question was, you gave the various models, the biomedical, the biopsycho, and the psychobio. I wanted you to just give us a clear distinction between the biopsychosocial and the psychobiosocial. What makes the two distinct? And two, I wanted to hear more about how I would now, when we are reviewing our curriculums, how we will incorporate spirituality in the 8 cadres of training that we have to train, because I'm seeing you have training, care, as well as corps outreach. Thank you.
Okay. Thank you very much, Professor Balida, for your question. I know you are a psychologist. So the argument here is that things begin in the mind with the cognition, and then downwards into the subconscious to create the internal mental dialogue we are talking about. And then one can project to the supernatural, and then before action occurs. So that the difference between psychobiosocial and biopsychosocial is really the emphasis of where to begin. So the beginning point in this model is the psychology, the mind, while in the biopsychosocial model is the biology. In other words, beginning with the diagnosis and perhaps remaining in that area alone if you are biomedical, looking at everything as disease, not knowing that perhaps it's because of the society and the culture, because of the psychology and such. So it's the beginning point. And eventually looking at the sociocultural aspect, which is why we are looking at the surroundings. So if we are to integrate this in medical teachings, we would start by asking a very simple question. We start at the patient level. We ask, do you have any beliefs, fears, worries in your life that you need to be considered in the session that you might be holding with them? So then they will now realize that perhaps they have some things to talk about. Maybe they are fearing that perhaps maybe they have problems with the mother-in-law and they are pregnant. And according to the naming system, maybe the child to be born should be named after the mother-in-law that they had. And that alone can make them get admitted to hospital with blood pressure rising and so on. So if then it comes out to the surface during history taking, then one can address it and show clearly that from the science, from the psychology and the surroundings, this is this. So it's possible. And then now it will differ according to detail. The undergraduates will be more general, and then the postgraduates will go deeper and deeper. Thank you.
Hello, I am Professor Onditi,
Yes.
Elias of Radiology and Imaging. Thank you for that very informative presentation, Dr. Nyongesa. I would want to know about numbers. We are 47 counties, but even when we were medical students, we came across psychologists and pastors doing their ward routines and every other part of the hospital. And now you are talking about clinical pastors, but with the psychological emphasis and spiritual emphasis. How many is your network starting from MTRH? How many are you? You mentioned several cohorts, but the numbers will assist us to know how you started and how you are growing and how it compares with the other models that existed before you initiated this one, so that we know how big is the movement locally and countrywide. Over to you.
Thank you very much, Prof, for your very nice questions. You are trying to estimate the magnitude of our strength. And I think I would like to say that we have not reached where we want to be, but we started off as a pilot in maternity here. And during that time, we were working with the North American colleagues, Professor Jim Lemons and his team. And then we used that to train. Up to now, we have trained nearly 20 chaplains, one can say, and they offer services in maternity. Sometimes they go over to a mortuary or areas where they have been called in hospital. And then we managed also now to train the previous chaplains who are in this hospital but not trained. And then those have now moved to form the pastoral care services in the hospital. But in my view, we are still very few, but we would like to increase this training. But so our next target then is try also to empower the nurses and the doctors so that, because from what they know in science, medicine, psychology included, it will not be very hard for them to understand how to put at ease these patients. Because what we are addressing here are really the emotions. We enable patients to overcome fear of not just the illness, but also fear of what else might happen as a result of the illness. First, they may not know whether they will die or not. They don't know who will take care of their kids. What is it that is going on at home while they are in hospital? It's such. So it's basically counseling, and it comes from logic, in my view. So what is needed is the awareness. So if we then train nurses and doctors, it will be possible for them to refer to the hospital chaplains. That's why I was calling it a subspecialty in maternity, because then the chaplains would concentrate for a longer time with the patients and identify the exact problems, because they are also able to make diagnosis and be able to give treatment through counseling. So I think we are making progress.
Dr. Simios.
Yeah, Dr. Smith's hand is up. Dr. Nyongesa, thank you for this very interesting presentation. And you can actually see that the attendance is over 100, meaning that, there are quite a number of us who were waiting to be converted in this presentation. And I also did not know that the spiritual corner that I see in referral, which has the Muslim place and it also has a Christian place, is actually associated with some of you, which is very nice. I'm interested as a comment to literally see the kind of curriculum you have. We know with these 4 or 5 cohorts on exactly what you are training them to do and say and practice. But my question maybe or my comment is, have we gotten an opportunity to go further on outcome? And the outcome obviously would be you're looking at the mother, you're looking at the baby, and I'm looking at also maybe other areas. An a patient presenting with appendicitis, and because of the issue of the mind, the body, the spirit, we then have a surgical condition subsiding. Have we had any studies on going further? The issue of association, the issue of cause effect in your presentation. You remember Professor Bell and the issue of witchcraft, him being very, very particular. Dr. Nyongesa, have you gone further in terms of maybe some studies on association, some studies on cause effect? Thank you.
Thank you very much for your very good question. It's not just one question. You started off with whether it is interdenominational or not. And I think I want to say that we don't favor any religion. The issue is emotional support, allaying fears and causing hope. So it's interdenominational. And then in terms of outcomes, I think what is worrying us is the scarcity of research in spirituality. Most of the research that we see are actually low level, low evidence level, maybe descriptive or case studies and so on. So here we moved a little bit further and reached numbers. We collected 384 mothers and then tried to make comparisons. So in other words, we are trying to enhance the nature of these studies so that they can be representative of the community that we are talking about. But I wish then we'd move to a randomized clinical trials, which I think is very possible now once we have agreed on the definitions and the difference between psychology and the spirituality and such. So it's an area of research in my view. But the current doctor can participate in this because it's just logic. Thank you.
Dr. Nyongesa, a question from Dr. John Ogot. Is there a link between the program and palliative care unit in offering end-of-life care for patients who request spiritual care?
The patients with the, let's say, cancer or who are on hospice management benefit from this because of the counseling aspect. So there is a link. But it's not only for people in hospice. In fact, we would like to move into maternity and deal with patients who are at different levels of disease. Thank you, John.
Dr. Geoffrey Mayo, your hand is up.
Thank you very much, Dr. Mercy. I wanted to say very briefly that I want to appreciate the great presentation by Dr. Nyongesa. We hear many times, of course, about thinking outside the box, especially when it comes to, in this case, aspects of human health. I wanted to congratulate you for daring to think outside the box, to considering, of course, spirituality as a component that needs to be taken seriously, of course, as far as healing is concerned. I wanted to follow up briefly on the comment that was made by my colleague, senior colleague, Professor Kwena, of course, regarding the biochemical basis of spirituality. And we got a good answer from Dr. Nyongesa. I just wanted to add, of course, to say, yeah, this is a very active area, of course, of research. In fact, there is hypothesis that is pointing to genetic basis, actually, of spirituality. There is a gene, actually, that is known as the VMAT2, vesicular monoamine transporter 2, that has been shown, of course, to be involved as far as spirituality is concerned. So basically, this gene is the one that normally transports neurotransmitters, specifically the monoamines, like the one that Dr. Nyongesa mentioned, serotonin, dopamine. So it participates actually in the transportation, of course, of those particular neurotransmitters, and in a way regulates, of course, the way our brains are actually conditioned. So I wanted to say, of course, yes, this is a very active area of research, and I think there will be probably other genes that will be discovered later on, of course, that actually play a role as far as spirituality is concerned. So there is the molecular biology basis of spirituality, and then there is the biochemical basis. And I wanted to ask Dr. Nyongesa whether in the curriculum, of course, that they teach now, they have actually started introducing, because he actually has mentioned electromagnetism and then biochemistry, and I'm now saying including genetics and molecular biology, whether these ones, of course, have actually been incorporated in the curriculum for training as they have it now in the Pastoral Center. Thank you very much.
Thank you very much, Geoffrey. I think your question gives me hope, together with Professor Nditi's question, because we are moving towards quantification. It means if we can measure these chemicals, if we can measure the magnetic fields, then we are moving towards quantification, and it will be now possible to make associations, as you have said. At the current moment, the course we are offering is a diploma, and one would not probably go in depth, but there are plans. If we can get undergraduates, PhDs, and master's degrees, then I think there will be opportunity for this. And we could easily be a leading center if we can put in some money in the COMESA area.
Thank you. I think as Dr. John Tabwe had mentioned, of course, there are likely converts, of course, and I'm, of course, one of them who would like to further study, of course, the role of biochemistry in spirituality. So you have me, of course, in your, what do I call it, the net of people actually who would be willing to contribute towards, of course, the development of that curriculum that includes, say, biochemistry, for example. Thank you.
Actually, I'm humbled, first of all, by the number of people who have attended and by what you are saying. And I want to say you are actually welcome. And I would wish to find a way by which we can win more grants to support spirituality for holistic health. It's not witchcraft, it's actually science. Thank you.
Dr. Nyongesa, witchcraft was used by Professor Bell, you remember, but I didn't mean to say this witchcraft. Thank you.
No, the witchcraft is misfortune, I think. So it's not for purpose of causing misfortunes, but it can also be used for that purpose. Thank you.
Dr. Nyongesa, question again from Dr. Galib Abdullahi. The presentation talks of spirituality and that it's not the same as religion. However, majority of the population identify themselves in terms of the religion they profess. How then do you come together to incorporate the recommendations?
Thank you. I think looking at the domains of spirituality, you can see there is a religious domain at the end. But or we could even put it first if we wish, but we are seeing integrity, we are seeing partnerships, we are seeing the environment, and then the supernatural part has now the religious part. But it's not the only spirituality there. So it's a small but significant component. And these four areas that I've mentioned, the three areas I mentioned before, do not oppose religion, unless somebody just comes out and says they don't like religion. So in the other words, spirituality, religion is a fourth component of spirituality. It's a component. I don't know whether I've answered Abdallah's question. You could include or exclude religion when you are counseling, but they enhance each other. Thank you. I'm seeing it's 4 or 3 now. I'm tired.
No, just one last question, Dr. Ari.
Okay.
This is JB still asking. My concern is the level at which you're still operating, which is at the diploma level, and yet we are talking about trying to roll it out under the COPS program. Does that mean that we have to put it at the undergraduate level, postgraduate level for it to be rolled out, or it can actually be rolled out from the diploma level in the respective communities where we take students for COPS?
You can do it from the diploma level, but I think undergraduate level would be very good. Postgraduate is good. You remember when, Professor, we invited you to reproductive health during the MFM program and there was COPS. It was very easy to insert spirituality at that point. So it can be at any point.
Maybe, JB, this should be a common course. It would be very interesting for it to be a common course if there's a revision of the undergraduate program.
Yes, and is that one of the recommendations which Dr. Nyongesa says? Because unless he makes that recommendation, we have no basis upon which we start operations.
I think I mentioned it in the recommendations, because the framework to me is a theoretical framework.
Mm-hmm. Yeah, that's why I was suggesting that if it's possible, then since curriculums are now being reviewed, is there a way that can actually be initiated so that we get to sensitize the various programs on the possibilities of incorporating spirituality in what they should be learning and why they should be learning what they're learning?
We are ready for that in spirituality. I think Professor Eunice Kamara was supposed to be in this talk. Unfortunately, she had some other duties away from here, and she thought we would record, but I don't know whether we recorded. If we recorded, then the most important recommendation in here is what you have said, that we integrate it in a medical curriculum, so that we have been struggling with a very simple problem. Do we medicalize anthropology or do we anthropologize medicine? And basically it means working together, the School of the Social Sciences together with the College of Health Sciences. I think that's how I see it. Then we move over to the community health workers. They will do it.
Dr. Nyongesa, one more question.
Yes.
From Dr. Jimmy Ruto. How do you exactly introduce spirituality? Praying, preaching, and how do you measure the impact?
Sorry, Jimmy, I want to say this. The question that we use is here. Do you have any beliefs, any fears, or any worries in your life that you need us to consider in today's session? That's how to open up. And then they will think about it, and then they will start to say they have worries, they have fears, they are hopeless. You know, hopelessness is next to death. So at that point now you are very worried that you want to save somebody from death. And then some come with beliefs, just beliefs. They believe they are bewitched. So it's an active question. Thank you, Jimmy.
Thank you very much, Dr. Nyongesa. Mercy Caronea.
Yeah, Mercy comes on. All of us have fears. All of us have fears, and the answer to the first question will obviously be 100% yes. Mercy, go ahead.
Would you be willing to discuss the fears so that we grade it? There are some that are easy to dismiss, but others are very critical. Like if you are staying in a house and you fear you might be attacked by thugs, you see that fear will make you not sleep. But it can easily be addressed and be told that maybe you stay near state lodge, so that when we have government security and nothing will happen to you. I'm seeing you are still raising hands. So can we?
Thank you so much. We have to wind up, unfortunately. Dr.
Yes.
Moko, please. Yes, wind up for us. Thank you.
We are going to make a presentation.
Just one more.
Okay.
Just one more.
That's the
Dr.
Dr. Mabea.
Nyongesa,
Yes.
this is a revolution.
Okay.
Revolution, and keep it up. Sorry, my network was a problem. When you say you are doing interdenominational, and from where I sit, I know spirituality is not just denominational. It includes even the beliefs we have in witchcraft and so on. So when you say interdenominational, are you considering also the so-called the people who practice witchcraft? Because from where I come from, the background, we are some of us are strong believers in witchcraft.
Let me answer that. That's Rogers.
Yes.
Thank you for your question. And that's the purpose of this presentation, to say that it's not witchcraft. But I think you want to know, being interdenominational was an entry point. But as we are willing to train healers, we are willing to train magicians, we are willing to train whoever. It's the issue of beliefs and emotions.
Wonderful. I'm happy.
Action.
Wonderful. I'm happy you are also approaching. You're also considering the other healers, not just interdenominational. Thank you.
Yes. And remember, I think in West Africa, my supervisor, who is not on this today, found it in use in university setups, University of Ibadan, University of Lagos. They have integrated this, but not the way we have done it here.
Thank you very much.
Chair, I think Dr. Nyongesa should come again. We need some study which shows that
the Kenya in June.
If you don't believe in something, then you are not healthy. And this thing must be spiritual, which could be religious or not religious. As long as you believe in some spiritual thing, then you are a healthy person. Thank you.
So long as you believe in the supreme, some higher power or some unknown. In fact, spirituality is extremely good for the unknown, the abstract. We'll present at the Kenya Medical Association meeting in June. Thank you.
Thank you very much, Dr. Nyongesa, for your presentation. Thank you, all of you participants. Let's meet again in the next grand round.
Thank you, Dr. Mwaliko. Thank you, Dr. Nyongesa, for such a wonderful topic. And have a good Easter, everyone.
Thank you.